whose work I read as a graduate student at the University of Pennsylvania. So I'm super excited to have the privilege of inviting him here today. So please come in and taste some cookies. Dr. Weisz is the Cotton Canada Chair of the History of Medicine at McGill University in Montreal. He received his PhD in history from Stony Brook University and in sociology from the University of Paris 5. His two most recent books are Chronic Disease in the 20th Century, A History, 2014, and Divide and Conquer, A Comparative History of Medical Specialization, 1830s to 1950s, published in 2006. He has also written books about the creation of French universities during the Third Republic and the history of the Paris Academy of Medicine in the 19th century, which are all excellent in a test. He has edited 5 collective volumes, including The History and Sociology of Quantification in Medicine and Greater Than Parts, Holism in Biomedicine, 1920 to 1950. He has written articles on mineral waters, national differences in gynecological practices, and efforts at international standardization, noticeably through practice guidelines of particular interest here in the He is currently working on institutions of global health, national and international efforts to organize effective primary care and trends in medical education. He's been a visiting professor at the École des Hautes Études en Sciences Sociales in Paris, the Max Planck Institute for the History of Science in Berlin, and the Université de Paris, the Sorbonne, and Amsterdam in Paris. And today we are lucky that he is here in Hamilton to join us. Please welcome Dr. George Weisz.
Thank you, Ellen, and thank you for inviting me. I come from an institution which has a very long historical tradition, and I'm actually honored to be at an institution which has a much shorter existence, but an equally significant, has had an equally significant historical impact on contemporary medicine. So I'm really pleased to be here. My topic is a genuine question. I can't really start a research project unless there's something that I don't understand. And the thing that I didn't understand about global health was something that happened in the 1990s where a relatively small scale venture that involved relatively few institutions suddenly in the 1990s exploded. And I began this research by asking what happened in the 1990s that made this explosion possible. So let me give you one example. This is from a paper that I did with some colleagues trying to map the global health literature, looking at things like clusters of citation patterns. But the really important thing here is if you look at it, you see the incredible increase in the number of publications that PubMed categorizes as world health, or more recently, global health. This is a look at funding since the late 1990s, and you see the same thing happening. There's an incredible increase in funding. I'm going to go back, by the way. I'm going to talk a little bit in more detail about these various charts. And the last thing is somebody made an attempt to try to map global health institutions in 2015. Now, if you look at this, it's absolute nonsense. It makes no sense at all. Nobody would put the WHO at the center of global health anymore. But what it does suggest very clearly is how many different kinds of institutions that now call themselves global institutions exist. So there is some question in the literature about how different this global health that emerged after 1990 was from earlier manifestations of healthcare in poor countries. This is a kind of an open question. My own sense is that the sheer quantitative change is important, quite apart from anything else. So let's start with what existed before we had anything like global health. So the first thing that I want to raise is something that many of you may know. There exists considerable international cooperation well before global health. There was an international, particularly trying to deal with the problem of epidemic diseases, international pandemic diseases. So in 1851, you get an international sanitary conference, which is followed almost every decade by other sanitary conferences, and it leads in 1907 to the Office International d'Hygiène Publique, while meanwhile in North America, the Pan American Health Organization is created to bring together North America and South America. So you already do have instances of international cooperation, mainly to deal with infectious diseases that might become pandemic. Now, another area of international cooperation has to do with statistics and with the classification of diseases. It began with a private initiative by a bunch of statisticians in different countries to try to standardize disease classifications so that you could make, never mind international comparisons, but even within countries, have enough standardization to have proper classifications. And it led to the first international conference which produced the international classification of disease that was adopted in 1900 and which has been reissued on an average every 10 years, reclassifications. A third area that is usually mentioned together with international health is global health, because this is where Western medicine becomes introduced in many countries in Africa and Asia. Early on, according to the historical literature, much of the emphasis is on the health of European colonists so that they can survive in these tropical countries. But by the 20th century, most colonial empires do have health officers, have systems in place to deal with the health problems of the indigenous populations. One place that's particularly important is the London School of Tropical Medicine, which both trains practitioners and does important research in areas of tropical disease. And I mention it here because it plays a rather important role in the development of contemporary global health as well. Finally, there is something that isn't always emphasized enough, and that's the role of missionary medicine and charitable societies in providing care for indigenous peoples in poor countries. I don't know if this person means anything to anybody under 50, but when I was growing up, this man was as famous as Albert Einstein. He was kind of the poster child or the poster man of charitable giving, Albert Schweitzer. So there's this very important tradition of missionary medicine that persists well into the 20th century and continues to exist. So now let me change tack a little bit and say that among historians there is a tendency to make a distinction between vertical programs that are imposed from above and the goal is to control, or in some cases to eradicate, very specific diseases using various sorts of medical technology, whether it's DDT to get rid of vectors, or vaccination to control diseases, and horizontal programs that try to develop healthcare infrastructure that is embedded in the communities and that grows out of the communities, and which also, to some degree, deals with social and environmental conditions that cause disease. And the historical literature is actually very consistent about this. The vertical programs are bad, and horizontal programs are good. People in global health may not feel quite exactly the same way, but historians and anthropologists are fairly consistent in seeing things in this way. I mention this because this distinction is going to come up in the course of my talk. So international health, as we understand it, begins during the interwar years. The League of Nations Health Committee, it dealt with a number of things. It was very important in standardizing chemicals, diseases. They're the ones who came up with this, with cancer stages, the 4 stages of cancer. But most of their work involved trying to deal with infectious diseases in poor countries, in underdeveloped countries. In spite of that, they had, by the 1930s, a number of left-leaning leaders who began to emphasize the social conditions that caused disease. And so much of the history of the League of Nations is very, very positive, because it reflects this sensitivity to vertical health solutions to problems. Simultaneous to the League of Nations, and actually giving a lot of the money that supported the League of Nations Health Committee, was the Rockefeller Foundation. The Rockefeller Foundation, which first of all created a whole bunch of schools of public health in the United States and in Canada. Johns Hopkins, Harvard, University of Toronto School of Public Health was funded by Rockefellers. And they also created schools in other countries. And they had a major international division whose goal was to deal with infectious diseases throughout the world. So they had a major program to eliminate hookworm disease. They had programs to eliminate malaria and yellow fever, and they provided the basic techniques to control these diseases that have become central to the way that global health functions. Now, these usually came from outside, and these are considered vertical. The other ones were horizontal. I take it back. The League of Nations was supposed to be horizontal. This is usually, the Rockefellers are usually considered to be responsible for what is wrong with global health these days by having from above programs that impose themselves on indigenous peoples. After World War II, a lot of things began to happen in international health. Notably, the United Nations created a number of organizations, particularly the World Health Organization, UNICEF for children, and a little bit later, a number of other UN institutions became involved in health. A certain number of governments, Scandinavia, to my surprise, Canada, was a major player in international health during this period through the International Development Research Council. And then there were a number of philanthropies. The Rockefeller Foundation, which sort of stepped a little bit out of the health area, the Carnegie Foundation, Médecins Sans Frontières. It was a fairly small world. And the chief organization was, of course, the World Health Organization, founded in 1948. Now, the World Health Organization, its original priorities were malaria, women's and children's health, tuberculosis, nutrition, and environment. It's become famous for an eradication campaign that actually did work, the smallpox eradication campaign. It nearly lost its legitimacy for an eradication campaign that did not work, the malaria eradication campaign, and as I'll mention, had a number of serious implications when it was clear by the 1960s that it had failed totally to eradicate malaria through such things as DDT spraying. It's also famous for its definition of health as a complete state of physical and mental well-being. For some people, this is a wonderfully enlightened definition of health. For other people, this is a wildly inappropriate ideal for a health institution to aspire for. It essentially means making people happy, and very few healthcare institutions are capable of making people happy. Is there a problem?
It's not showing up.
It's not showing up. We've lost it. Okay. Let's see if changing it makes a difference. No, it doesn't make a difference. Excuse me?
He's restarting it? Is this still working, the video conference?
Sorry about that. I usually don't have a problem with this. Okay, so that's the World Health Organization, which was the dominant healthcare institution for much of the second half of the 20th century. The failure of the smallpox eradication campaign led to a reaction, a major reaction. This one has stopped working. Okay. And it led the WHO to create a new program called Health for All, focusing on primary health care, which was a vision that was made famous at the Alma Ata Declaration of 1978. It was a vision for bringing the essential conditions of good health to even the poorest countries through community participation, and it was the basis of WHO policy for nearly 20 years. Almost immediately, a number of figures at the Rockefeller Foundation introduced an alternative to primary health care, which they saw as impossibly ambitious during a period of scarce resources. Remember, this was the 1970s and 80s where there were major economic crises. There was the oil crises. There was budgetary financial crises, and they proposed instead to focus on a very small number of high impact practices that affected major causes of morbidity and mortality. So one was again seen as horizontal and the other was seen as vertical. I recently reviewed a book where there was a picture of the two major figures who were involved in this. Halfdan Mahler is to your left. He was the head of the WHO for about 20 years, and he was the spirit behind primary health care. Kenneth Warren was a parasitologist who worked for 10 years at the Rockefeller Foundation, and he wrote he was co-author of the original paper on selective primary care. Okay, this is all real background to the 1990s when things really begin to change. A number of things happen. First of all, WHO goes into major crisis. Everybody is criticizing the WHO as a bureaucratic institution. There's a lot of pressure to create independent institutions that are free of the bureaucracy of the WHO. And the WHO responds with a plan to basically reform its administration, which doesn't actually go very far. But one of the things that they decide to do is to work more closely with the World Bank that has, since the late 1980s, become increasingly involved in healthcare from its perspective of economics and economic sustainability. And the World Bank, with the help of the WHO, produces what is probably the most influential and consequential work of the 1990s in global health, called the World Development Report of 1993. It argues that health is central to development and should be central to development spending. These are economists who are writing it. In fact, the chief economist is a guy named Dean Jameson from UCLA who worked for several years at the World Bank. And they have a cost-benefit view of how to spend money. And they actually develop metrics for evaluating health problems that I'll talk about in a moment. It's often associated with something called neoliberalism, which is a term that I have a lot of trouble understanding because it's used in such an incredibly vague way that even anthropologists are beginning to complain that it's lost its meaning. But one of the things that it's clearly one of the reasons it's associated with neoliberalism is that it argues for expanding global health beyond international institutions to include philanthropies, NGOs, and even multinational corporations, that you can't, for instance, improve nutrition unless you get the multinational food corporations in some way producing the food that would improve nutrition. I mentioned metrics. One of the things that grows, that is introduced by the World Development Report, is the Global Burden of Disease Project, which was organized by Alan Lopez at the WHO, and mainly Chris Murray, who was then at Harvard. And one of their main innovations, aside from the fact of trying to get better statistics for poor countries, which were actually terrible and more or less useless, was to introduce the DALY, the Disability Adjusted Life Year, as a way of summarizing a whole range of mortality, morbidity conditions. Initially, because it was economists, they gave different values for different ages, which infuriated almost everybody. So in later iterations of it, they abandoned it. But this has become one of the things that truly holds together the global health, because they have been producing statistics for the last 20 years that everybody who is trying to get more funding and a greater recognition can use their statistics. So whether it's mental health or whether it's chronic diseases like cardiovascular diseases, everybody uses the statistics of the global burden of disease in order to indicate just what a big problem there is in the world that needs to be solved. Now, one of the ways in which the World Development Report and the global burden of disease gets spread through the world of international health is through research. And in 1987, there's an international commission, nothing to do with the WHO, on improving and rationalizing. It's the Commission on Health Research for Development. There's this incredible emphasis on health research. And some of you may recognize the man who was president of this commission. Does anybody recognize the man who was president of this commission? It was John Evans, who, after he was the founding director, of course, of McMaster, he was dean at Toronto. In 1980, he became the founding director of the World Bank's Population and Health Department. And in 1987, he became chairman of the Rockefeller Foundation. And it was in that capacity that he was officially the director of this report on health research, which became famous because it argued that most research, 90%, which is out of the air but is meant to give a sense of scale, 90% of research went for diseases of 10% of the richest population. And the WHO was pretty much forced to follow, and they created an independent ad hoc commission on health research, which included a number of people from the WHO. But again, the lead author of it was Dean Jameson, who had written the World Development Report. And what it basically argued is that the ideas of the World Development Report had to be applied to planning research for international health. This applied in many other, and this was applied in many other domains. In 1998, Gro Harlem Brundtland becomes head of the WHO, revives it, and brings many of the people who were involved in the World Development Report, Chris Murray, Dean Jameson, all of these people come to the WHO, and as one of my leftist friends said, they were all shills for the World Bank, which is untrue, but the point is that there is a merging, there's a serious merging of the ideas of the World Bank and the WHO. And the other thing that comes with it is a major increase in funding that I'll talk about in a moment. The other thing that happens in the 1990s is of course the follow-up of the HIV/AIDS epidemic, Ebola, a number of emerging antibiotic-resistant tuberculosis. The whole notion of emerging and re-emerging diseases causes terror, absolute terror throughout the world, but particularly in the United States. and a book by a Nobel Prize-winning biologist, Joshua Lederberg, unfortunately gave the fear of a major pandemic a rational basis based on evolutionary theory. That evolutionary theory, the mutation of antibiotics, made it extremely likely that we would eventually be facing a whole slew of new epidemic diseases. And very quickly, the American government in particular gets extremely involved in this. Congress begins to hold hearings. This is a report by the National Science and Technology Council on infectious disease. As you can see, there, just about every major department of the US government was a party to this report. So this creates a major terror that led in 2005 to the creation of a new global surveillance system, which has worked more or less. Sometimes it's worked okay, and sometimes, like the latest Ebola thing, hasn't worked so well. But this really puts the notion a global epidemic is truly global, and it puts global health on the map. Another thing that happens is HIV activism. By the late 1990s, we have antiretrovirals, which are far too expensive for most of the people who need them most in Africa and Asia. And there are major, major campaigns in order to make these antiretrovirals accessible to poor people. It leads to campaigns throughout the world, and eventually they are successful. The drug makers who make the antiretrovirals make them available relatively cheaply. Still a little bit too expensive for the world's poorest people, but nonetheless cheaply enough so that NGOs can at least afford to buy them and give them out. A third thing that happens is that in the late 1990s there's a reaction to globalization, to the economic effects of globalization. There are manifestations, there are riots that take place each time the countries of the G8 meet. And one of the effects of that is, it's been argued, is to convince the G8 countries that they really have to do something. And one of the things that's easiest for them to do is to significantly up their spending on health care for poor countries. So the G8 countries and later the G18 countries ramp up their spending on international and global health fairly dramatically starting at the beginning of the 21st century, with the American program PEPFAR for HIV/AIDS probably being the largest of these projects. And finally, the last thing that happens is some very, very rich people decide that health among poor people is extremely important and should be a priority. For those of you who don't follow music, that's Bono over there with Bill Gates. In other words, it becomes a celebrity issue. Global health becomes a celebrity issue, and it is on the map. It is on the world map. So a lot of things happen, but structurally the most important things are a number of strategic alliances. The first one was the Global Forum to try to coordinate research. This is something that I've just written an article about. It turns out to have been a terrible failure. It eventually was swallowed up by another institution, but it was the first time that everybody from scientists to politicians to pharmaceutical companies to administrators were supposed to get together and try to rationalize health research. Much more successful was Gavi, the Vaccine Alliance, because they got a lot of money from the Gates Foundation, and they have been fairly successful both in producing new vaccines and in making them available in poor countries. Again, all of these are independent of the WHO. They're independent institutions. And the biggest one is the Global Fund to Fight AIDS, Tuberculosis, and Malaria, which has become probably the largest distributor of funding in the entire global health arena. And of course, there are a couple of new influential institutions. In a class by itself is the Bill and Melinda Gates Foundation, where they've become geniuses in giving small amounts of seed money that then gets other people to give much larger amounts of money. So what we have is now, and the other thing that happens, of course, is that the number of groups and institutions and agencies involved in global health multiplies geometrically. And so you get this totally fictional map of global health institutions, but it gives you an idea of how many different kinds of global health institutions now exist. There are literally thousands. There are literally thousands of institutions, and the fact that they very often compete with each other and contradict each other has led to more articles than I can possibly count on global health governance. How on earth can you coordinate all of this stuff that's being done by all of these people? Now, I showed you this before. I will show you again. This is a map of global health funding, which, as you can see, starting around 2000, went up about 400%. About 400%. After 2008, it sort of stabilized, and now that Trump is in power, I suspect it's going to go down. But there was this huge increase in funding. If you look carefully, most of the funding comes from governments. Including the Canadian government right over here. Of course, the American government is the biggest provider. But you can begin to see how. You can begin to see how private institutions, green institutions, are beginning to take up more and more space. But this is donations. This is not spending. If you look at spending, you see that governments have shown a preference for actually giving their money to established global health institutions, a little bit the WHO, not very much, but certainly Gavi and the Global Fund and other foundations. So there is this money is coming largely from governments and from some foundations, but it's largely being spent by private NGOs and philanthropies. Now, once something becomes this big and this visible, naturally universities want to become involved. And starting around 2000, you begin to see one university after another creating programs of global health. And one of those universities is my own university. I always like to say McGill does stuff 5 years after Harvard does it. In the case of global health, it's more like 10 years. It took 10 years for McGill to realize that global health was an issue, so they hired somebody to pull together the 4 or 5 existing programs, isolated programs that existed in places like Kenya and Ethiopia, and create this global health program at McGill. They've gone even further and created on paper in the medical faculty a new school of population and global health. So when McGill does something, you know that it has become truly, truly mainstream. Because as much as I love McGill and as much as I appreciate my time there, it is not known for its innovative activities. So we know where global health is. Okay, so what happens when universities become involved in global health? Well, naturally, they have meetings and they get together, and you have the consortium of universities of global health. I'm not even, every time I do this talk, I have to change this number, because every time I look on their website, there are at least 4 or 5 more academic institutions that have joined. But anyway, the last time I looked, there were 153 academic institutions, and of course, funding comes from the Bill and Melinda Gates Foundation and Rockefeller, and the idea is to create collaborations among universities. And I must say that their annual meeting has probably become the biggest global health event that now exists, and I can tell you this for sure because our dean attended last year for the first time. Our dean of medicine attended. So, what happens when you have academics involved in global health? Well, you have a problem. What is it that you're actually teaching? What is the content of the global health that you are trying to teach? And naturally, the leaders of the consortium of Q came up with a definition that I'm not going to read to you, but it's probably become the most cited definition of what global health is. And if you look at it very carefully, you'll see that it includes pretty much everything. There is very little that you would think of that is not included in this definition of global health, which I think is, I'll come back to, is one of the problems of global health. The other thing, of course, that is very, very real is when academics become involved in an area, they publish. They publish a lot. And this is an article that I published about a year ago, a little less than a year ago, mapping the global health world. But before we actually started mapping clusters and looking at citation connections, we actually counted using PubMed. And you can see the huge increase that has taken place in publications that are identified somehow as global health. We stopped in early 2015. I'm thinking of doing a continuation of it in the last 3 years, because there's something like 4,000 to 5,000 articles that are added every year to this global health literature. Okay, so global health is now this major social, I don't know what to call it, enterprise. It's a major social enterprise, but it is not without major tensions. As I mentioned, one of the chief ones is vertical programs versus horizontal programs. All of the discussions talk about both as being necessary. You have to deal in some cases with specific diseases. You have to deal in other cases with providing health infrastructure. If possible, you can try to do both. But the reality is that most money goes for vertical programs because diseases are something that people can identify with, whereas creating clinics, infrastructure is a little bit more difficult to show results. You can show results if you're trying to manage or eradicate a disease. It's harder to show results if you're creating clinics. Now, to some degree, this is a political division between what I would call a political right and a political left. It's not an exact match, but there is some of that. It's very much a temperamental division, very often under conditions of scarce resources, and resources remain very, very scarce for the poorest countries. You have a choice between pragmatic solutions that are going to save lives immediately, or longer-term solutions that may deal with the deeper causes of what the problem is, but will take years and years to actually make a difference in the health of people. And this is a basic tension that I think resides a lot in people's temperaments and in their views of the world. It's also a question of strategic choices. You know, short-term solutions that will have immediate effects versus long-term solutions that may down the line have more profound effects, but we don't really know that. But we think they will. We don't really know, but we think they will. Part of the division, again, between vertical and horizontal is that vertical solutions tend to be, if not specifically medical, at least technological. So, for instance, for malaria, it's about killing vectors. Okay, for many other diseases, it's about vaccines. It's about a technological, biological solution to what is perceived as a largely biological problem. On the other hand, there are those who argue that it's the environment that's making people sick. You've got to give people clean water, better nutrition, a little bit more money in order to raise their living standards. The medical and technological is clearly dominant, but the environmental, the socio-environmental is there as a reminder, as a constant reminder of what global health should be doing according to many of its critics. There is, even though everybody talks about equity and versus cost effectiveness, everybody wants cheap solutions, and everybody wants those solutions to be equitably distributed. The reality is that very often you have to choose. You have to choose between people who are suffering immediately, or solutions that where people may not be suffering quite as intensely, but many, many more people will be affected. And this is one of those tensions that constantly comes up, especially in our world of social dislocation and war and migration, large migrations. There is a constant critique of global health that funding is not transparent, or at least responsible. It's not democratically allocated, that people like Bill Gates should not be deciding where money for global health goes. It should be communities themselves that make their own decisions. To some degree, funders have internalized this criticism, and they now solicit projects that they then agree to fund. But of course, as academics, we all know that you frame projects in ways that you think will get funding from particular funders. So I'm not sure that this solicitation really solves that critique, or that even that local communities necessarily are nobody has really explained what local communities are. Is a local community in India that's divided into castes, where you can be pretty sure that the lower caste members have no say in whatever decisions are made about priorities. So it's a serious problem of definition. One of the big debates that's going on is, and this is how I got involved in global health, it's become increasingly clear that non-communicable diseases are becoming a bigger and bigger problem, even in the poorest countries. And I can tell you that the amount of literature on this, the number of statements by important organizations. The UN even had a special meeting on non-communicable diseases, is huge. And non-communicable diseases roughly get 3% of external global health funding. So this is a real tension, partly because infectious diseases are much more immediate. Solutions are much more immediate than solutions to chronic disease problems. And people already have ongoing investments that they can't just drop in order to spend money on heart disease or cancer. And my last point, the last tension, is the one I think I alluded to, the tension between rhetoric and action. The global health community is made up of geniuses in coming up with declarations that bring in everybody's interests into some kind of compromise definition that everybody can live with. The Q definition of global health is a very, very good example of this. Almost everything you read includes all of these tensions that I've spoken about, and basically says they're all important. Everything is important, and everything is a part of global health. Unfortunately, these kinds of declarations do not necessarily translate into action. They do not necessarily translate into action, and when it comes to action, there is a real tendency to focus on vertical solutions that bear almost no resemblance to the rhetoric that produce them. So what is global health? I think it's vague enough that everybody can have their own definition. My definition is a fairly simple one: a bewildering number of institutions and individuals pursuing divergent, often unrelated goals, usually directed at poor countries, although sometimes they can be directed at indigenous peoples in rich countries, and who spend considerable time trying to define what actually links them together and discussing if and how they can work together. And with that, I'll end, and thank you.
So we have about an hour for questions, so make sure Dr. Weisz gets a handle those.
Yes?
Is global health a new colonialism?
That's a really good question. Part of the issue is global health neocolonialism. There is a group, mainly of historians, because global health people don't usually know history, but certainly historians of colonialism have people like Warwick Anderson and a number of other people do argue that it is at least linked to colonialism in the sense that the transmission patterns of healthcare are based on colonial institutions. There's a tendency to buy pharmaceuticals from the home country. And some of the mistrust of global health institutions stems from the mistrust that indigenous peoples had for their colonial rulers. There's a very famous anthropological article that I don't remember the name exactly. It dates from the early 1960s, where the argument is that colonial peoples in East Africa basically associated European healthcare with vampires and vampirisms, because the healthcare producers were constantly taking their blood. They were constantly taking their blood for testing and for research. So that there are vestiges of neocolonialism, for sure. Is it itself neocolonialism? I don't know. I don't think so. I think Randall Packard wrote a book on a history of global health, a very good view of global health, and he spends a lot of time on colonialism. And somebody wrote a review in a global health journal and said, enough with this colonialism stuff already. It's been 60 or 70 years. You know, we have more immediate issues and more immediate problems. So my sense is, yes, there are links, but I think that there is something fundamentally different between colonialism and this new kind of activity in formerly colonial countries. Yes?
Could you talk a little bit more about the crisis in the WHO in the 1980s and early 1990s and what the sources of the crisis are?
Oh boy. Well, there were a number of things at play. One thing at play was a very, very poor choice of a Director General. A very, very poor choice who was universally criticized for not doing anything. Okay? The other standard criticism was that the WHO was this bloated, bureaucratic institution that was really incapable of doing very much in the real world. A third criticism was that it had become so involved in contributing to projects on the ground that it was no longer providing leadership, you know, providing the norms and larger strategies that countries could utilize in order to improve things for themselves. Finally, there was a political dimension. The Americans were very unhappy with the WHO, as they are unhappy with many UN institutions, because there are many countries who do not share their values. As a result, they didn't attack WHO directly, but a whole bunch of countries began, rather than contributing to the normal regular budget, they began contributing for special projects that they themselves particularly cared about. So there was this crisis, this budgetary crisis, where individual countries, rich countries, were supporting a variety of their pet projects, and the WHO regular budget was in crisis and inadequate, and gave the institution very little margin in order to do anything. And if you look at 1993, 1994, the journals, the medical journals that were really interested in international health, like the British Medical Journal and the Lancet, have at least 7 or 8 articles on the crisis of the WHO. All of these things sort of came together and created this sense of crisis that was shared by the WHO. Is a huge organization, and there are people, there are certain groups within the WHO, like there's a tropical disease program that has always been very close to the World Bank. Always been very, very close to the World Bank. And they were, and so even within the WHO, there were groups that were deeply unhappy with the leadership of the WHO. And that sort of remain unhappy. Brundtland only did 1 term as Secretary General, and she brought in a huge amount of vitality and new money and new people, but she stepped down after 5 years, and there are many of the issues remain. Many of the issues remain. When I submitted my article on the globalization of chronic disease to a journal of population studies, one of the reviewers said nothing about the paper. All he kept talking about was the last meeting of the World Health Assembly, and how they had failed to introduce any of the reforms that they had promised to introduce. He didn't say a word about my paper. He was just so angry about the WHO. So it remains a somewhat problematic institution, but if you want to work, if you want to do historical work, it is a great a great library. Unfortunately, they're destroying their archives en masse, but it's a great place to work in a very pleasant space. Yes?
Making an observation of the role of China since the 1990s in world health. Are they playing along with the team, or are they going?
They're not with the team.
I've never seen them on that chart.
They are totally off the charts. They're doing their own thing. I don't know what, I mean, we know what they're doing in terms of roads and railways and, infrastructure. We know all about that. I'm pretty sure that there is a health component to this, but we know very little about it because the Chinese themselves don't really publicize it very much. But they are off in a corner doing their own thing. They're clearly doing their own thing. Unlike the Russians, when they came back first they left the WHO, and then they came back in the 1960s and in the 1970s. They were extremely insistent on being given responsibility over having real power over WHO policy. They were extremely insistent on it. In fact, the chronic disease department of the WHO in the 1970s and 80s was exclusively made up of Russians and people from the satellite countries. To the point was that there were rumors that it was really a KGB front, that the whole department was a KGB front. Yes? I sort of hear you. Okay, so far I hear that she was interested in my chart about publications and how they've increased to such a degree.
Right, and usually you see that that was the symptom of global health being sort of
An academic entity. An academic entity.
And then you also mentioned something about community participation, which I think is really our discussion in global health research now. So I'm wondering, when you combine those two aspects, the idea of the scientific community or the global health academic community, and the idea of community participation, you end up going into the domain of
Value.
for Southern innovation. So when there's Western researchers that are going into these local communities, what sort of value do local researchers play there? And whether you think that's a gap in global health research now, or if that's already been dealt with previously.
This.
Can you repeat the question?
The question is, given the academic interest on global health research, what is the role of local scientists in this research, and is there a gap? Okay, this is my new project. Okay, my new project is about global health research, and I can tell you that from the 1970s on, developing research capacity in poor countries has been a major priority. It's been a major, one of the reasons that the WHO's TDR, Tropical Disease Program, was so successful was that it devoted about 25% of their budget to training local people. That being said, many people have been trained. If you look at a lot of these articles, you see African names and you see Asian names. That being said, when you look at discussions of global health research in 2017 and 2018, the lack of local participation remains a major topic of conversation. It's a major, major topic of conversation. So you go to meetings now, you see Africans, you see Asians. There are many more than there used to be, but it is still perceived as a major, major gap that the ideal of countries being able to solve their own problems remains very much an ideal, and almost every day, there's a new suggestion for improving matters.
How many of those 153 universities in that consortium are not from North America and Europe?
That's a very good question. The vast majority. There are a number of African.
The vast majority are not from North America and Europe.
Yeah, North America, the vast majority. Now, there are a number of African countries, African universities and Asian universities, but I haven't really done a calculation. But they're a minority.
There's a book called Dead Aid. Have you ever read that book?
No, Dead Aid?
Yeah, I know Neil Ferguson was at the forward, but it's basically saying that all these NGOs and things are preventing the countries themselves taking the issues and sorting them out for themselves.
Yes.
That's the basic, which I think is what you're saying.
No, I'm not saying that. I'm saying that the ideal has been, since the 1970s, and certainly when research became a hot topic in the late 1980s, the ideal has been for countries to take charge of their own problems. The problem is that it costs a great deal of money, and it's very difficult to solve some of these problems. I think you have to distinguish between countries like Brazil, which are middle-income countries, and countries that are low-income countries. And I think it makes for a good ideological and rhetorical point that there's no need for the West to be involved. But that's okay if you accept famine and you accept infant mortality. The answer is that I don't buy that. I don't buy that. I think that what people have been trying to do is very difficult, and it hasn't necessarily been successful, but you do try to create local capacity, local research capacity and local health capacity. And some places have, for this project that I've just submitted to SSHSA, I have two African sociologists who have agreed to work with me on this. So there is stuff that really is happening, but it takes a lot of money. It really takes a lot of money that many of these countries just don't have. And that's assuming that they're not ruled by corrupt dictators who send all their money to Switzerland or the Cayman Islands or some other place. Yes?
I'm curious if these things that have a sort of convergent goals of the global health security agenda, global sort of they work together and all that.
All right, so the question is, what is the relationship between the security agenda and the aid agenda? And it's interesting. There is not. The answer is that there's not a great deal of connection. An anthropologist has written an article which is a little bit simplistic, where he talks about the two regimes of global health. One regime is the security regime. Okay, the security regime is about surveillance and locating and trying to stamp out epidemics before they travel around the world. We saw this with SARS and H1 or whatever it was. The other one is the humanitarian regime, which can be cast in a variety of different ways, as development, as human rights, as Christian charity, as it can be cast in a number of ways, but that works on a rather different register, a very, very different register from the surveillance. For one thing, you have much less private enterprise involved in surveillance. The private enterprise and the philanthropies and all that stuff is in the humanitarian regime, whereas the surveillance regime it's largely governments and international agencies like the WHO, which is supposed to coordinate everything. Yes.
Do you know the role of the pharmacy industry in global health, and if they are kind of in that realm, does the efficacy of them like dumping drugs that are like outdated and stuff in these old countries like Ireland like that will develop of these global health programs that we could be something?
Okay, I mean, the question was, what is the role of the pharmaceutical companies in global health? And specific mention was made of dumping of drugs that are not efficacious. The two things are totally different. One of the things that distinguishes global health, and I think this is a real difference between global health and what preceded it, is that the people who are now responsible for global health believe that everyone, including the pharmaceutical companies, need to be involved. And the reason for that is a very pragmatic one. It's a very pragmatic one because nobody, not the WHO, not the World Bank, is capable of producing new medications and bringing them to market. It takes a very, very specific expertise in order to do that. And so pharmaceutical companies are definitely involved. They would like to, in some cases they're doing it to make money. Although in the case of HIV drugs, they basically agreed that it's too important to try to make money off of. In other cases, they're doing it for prestige, in order to prove that they're good global citizens. That's very different from, I don't think you'll find too many large, serious multinational pharmaceutical companies that are dumping ineffective drugs. That's clearly a no-no. That is not part of the deal that pharmaceutical companies have made. That being said, one of the things that we looked at when we were mapping things was the web of science since 2007 includes funding for all articles that get cataloged in the web of science. And it's very interesting. You see a kind of, the institutions that you would expect, the NIH, the Gates Foundation, the Wellcome Trust, in kind of the center. And along the margins, you see the pharmaceutical companies that are paying all kinds of people to write articles and to do research. This is one of the things that drives what I would call people on the global health left crazy. It drives them nuts that companies that are making money out of drugs are actually making decisions about global health. And it's a real... I don't think it bothers that many people who are actually doing global health, but it certainly bothers the historians and the sociologists and the anthropologists and some of the activists, some of the global health activists. So yeah, this is a real issue of tension. But the whole raison d'etre of this new global health is to include everyone, is to expand resources way beyond what countries and international organizations are capable of doing, And therefore, to make the pie much, much bigger so that you can then allocate resources. You have more resources to allocate efficiently. There was somebody on that side, yeah?
Yes, thank you very much. I really enjoyed when you demonstrated global health as very heterogeneous and amorphous concept within the domain and through the tensions that you described. And you sort of see how you don't land on the things that will global health in a specific way. But I'm curious to, from your perspective, to know how much you think that these tensions and they're sort of being buoyed up by this moral imperative to save lives or having the problem of saving humanity. To what extent these tensions actually contribute to a paralysis in terms of moving forward with a more multi-directional, instead of vertical and horizontal, but a more multi-directional approach and transdisciplinary approach to addressing some of the challenges we see today?
That's a really tough question. My own sense is that these criticisms have an effect, but the fact is that Bill Gates will spend his money on what Bill Gates wants to spend his money on. The World Bank will spend its money on what it wants to spend money on. The criticisms that I'm describing, I think it would be fair to say that they're quite marginal. They're quite marginal, and that people sort of shrug their shoulders and say, well, that's just those university professors, those academics. What do they know about the real world? So I don't think that it's a cause of paralysis. I think what is a more serious problem on the ground is to have a dozen NGOs in the same place doing overlapping things in different ways, and that causes real problems. That causes real problems, and this is there's ongoing debate about that because it's very hard to control what goes on the ground. It's Yes.
Can you say something about the interaction of war and global health?
Yeah. One of the arguments that Randy Packard makes in his book on the history of global health is that one of the reasons that you have such specific vertical programs to improve health is because so much is happening during periods of crisis. During periods of crisis, you can't really think about long-term issues like providing proper infrastructure that may come online in 5 years or in 6 years. You've got to deal with the immediate problem. And one of his arguments is that this is because we live in a world where there are constant crises, and this was true after the Second World War as well, that this disease-specific, top-down approach to global health is partly the result of the fact that you need to act immediately. You need to act immediately and provide people with immediate relief. So without knowing a great deal about it firsthand, it sounds like a very, very plausible reason for some of the strategies and orientations that global health tends to take. Yes?
There's been a lot of different tensions in global health. There's an ever-increasing number of publications related to global health. And clearly, everyone's got their own idea of what global health is and what it wants to be. And I was wondering if there's any path forward that will bring everyone together and have everyone on the same page of what everyone's trying to accomplish, or is it just going to continue to become further fractionated as a discipline?
Well, I'm a historian. I can tell you what happened in the past. I can't tell you what's going to happen in the future. The only thing that I can say is that since the 1970s, the desire to get everybody on the same page and to cooperate has been huge. You know, some people look at neoliberalism, and I look at this desire for collaboration and cooperation from everybody as one of the really key things that defines global health. That being said, it's a wonderful ideal. It's led to a bunch of new institutions. But the reality is that there are many, many different problems that are faced by, that are part of the world of global health. They require very different kinds of responses. And it's very hard to imagine a situation where people can agree on strategies on anything beyond the rhetorical level. On the rhetorical level, they agree, believe me. They agree on the rhetorical level. It's in practice where it becomes very, very hard to get people on the same page. I mean, everybody agrees that more money needs to be spent on non-communicable diseases. But it's not coming. I mean, it is coming, but at the same pace as the rise in global health funding. It's still the same percentage as it was. So the answer is, I can't really predict, but it's very hard for me to see a major change taking place. Yes?
What have been the most successful examples of horizontal interventions in the past?
That's a very good question, and I am not...
Too early to tell.
No, there have been horizontal interventions. There are countries, African countries, that have successfully created health centers in rural regions. The problem with it is that there has not been a lot of evaluation of these things, at least not that I've read. I mean, there may be people whose job it is to evaluate programs who would probably know a lot more than I do, but because there are relatively few programs of this sort, I really can't tell you very much about which ones have been. Thailand, for some reason, is always cited as one of the great successes, in spite of being a very poor country. It's cited as a great success in bringing accessible health care to its population. I'm not sure exactly why that is the case. Maybe it's because, unlike its neighbors, it hasn't had decades and decades of war, but it's considered a great success. Yes?
So your definition of global health on this slide here.
Which is a little bit tongue-in-cheek.
Right, absolutely. So originally I was going to ask whether you thought that global health initiatives could be more effective if we spent less time having these sort of interdisciplinary discussions, right? But then when you were answering the question here behind me, you said it's a real problem that there are different stakeholders doing similar overlapping things. So, I mean, and in that case, it seems like this conceptual cartography is really necessary. So I'm wondering, where you stand on that.
I'm not sure I understand your question. When you say the question is...
Like the mapping out of things that we're doing, right? We're spending considerable time trying to define what links together and discussing if and how they work together, which seems tongue-in-cheek. So originally I was going to ask, do you think we should spend less time doing that, right? Is it going to be more effective if we're
think I would make a couple of distinctions here. The first distinction, and one of the things that disturbs me a little bit as a historian about the global health enterprise, is how much rhetoric is involved here. And I sort of wish there was less rhetoric, because as a historian I have to read a lot of this stuff. And believe me, it's exhausting and a lot of it is not fun. On the other hand, people on the ground have got to work together. And that's not going to happen because the WHO comes up with a statement. That's going to happen because the various groups that work together make decisions about how they're going to divide up the terrain and how they're going to do things. So, I think there are serious decisions that really do have to be made at the global international level about what international or global agencies, what kinds of things they should support, and what kinds of things countries should individually be doing, which would be guidelines, basically, for how things should function. And then there's the kinds of agreements that need to be made among thousands of organizations who basically are ignoring each other. Basically, even when they're in the same place, they don't necessarily have a lot of collaboration. So I would distinguish between the two things. That being said, I think the only reason the main reason we need to define global health is because it's now an academic subject, and we need to know what it is that we're teaching. Okay. Beyond that, and until now, people got along, for better or for worse, by just going to places and doing things, and not defining necessarily what it was that they were part of. What was the grand enterprise? So I guess that would be my non-tongue-in-cheek answer. Yes?
My question concerns large corporations as well as organizations. So looking at the World Bank, for example, on one hand, we understand that it's a large global health center. And on the other hand, from a more political science realm, you can see how the World Bank has been involved in implementing certain policies that restrict economic development in low-income countries, and that ultimately decreases social determinants of health, but also people affecting their well-being. And my question lies along the lines, how do you make sense of this duality that seems to exist, of the positive and negative impact that these large corporations and organizations need to have in global health?
Well, the World Bank is not a large corporation. It's a UN agency. And it's run by economists and bankers who think a certain way. And like the WHO, it's a very heterogeneous organization. The personnel change on a regular basis. There are different departments that have different policies. And the problem is, where a lot of anthropologists in particular, they lump together everything that the World Bank does into one thing. So for instance, the World Bank did something that I think is genuinely considered bad in the 1980s, when there was a world banking financial crisis, when many, many poor countries had huge debts that they could not possibly ever pay back, and whoever ran their banking division, their loan division, decided, which many Western countries do as well, that the only solution was refinancing the debt and introducing austerity measures, cutting budgets, including health budgets. Okay? So that was a kind of a banking decision. In 1989, a different branch of the World Bank that was responsible for planning decided to try to work out some form of sustainable financing for health in poor countries, and they produced, among other things, the World Development Report. They produced a whole range of writings. They were among the first ones to talk about the importance of non-communicable diseases as a target for action. And there the goal was not a banker's goal. There the goal was trying to find a sustainable way of financing what was recognized to be a huge need, and which called for much, much more money being spent on health. I think once you understand that the World Bank has many faces, things become a lot clearer. As far as corporations are concerned, you know, that is a real issue. One of the areas where the World Bank has tried to work very closely with corporations is in the area of nutrition, working with food companies. And the argument that Brundtland actually made, she actually made this before the WHO, she said everybody was for an anti-tobacco world agreement. She said, food companies are not tobacco companies. If they don't produce the food, who is going to produce the food? There's no way we can avoid working with them. That was her argument. The problem is, after 15 years, the food companies have done very, very little to improve the nutritional quality of much of the food that they send to poor countries. That's the price you pay. On the other hand, the WHO doesn't produce food. You know, they're not a food, so they're kind of powerless by themselves. And you know, working with corporations whose main goal is profit can be very, very problematic sometimes. It can be very, very problematic. Yes?
So I know that, for example, one way of defining what global health might be defining in someone is what it's not. So I'm wondering, I hope I'm not opening up on understanding words, but how, if possible, could we distinguish global health from similar disciplines of public health, population health? Where do we make that distinction? And even in the literature, when we look, that all of these bodies of knowledge are very much so.
Well, you know, the simple answer is that everything is being lumped together. There's a famous article in probably the most prestigious public health journal in the world, a British journal called Public Health, whose title is "Public Health is Global Health." Okay, it's so certainly in the public health world, every school of public health is either adding global to their name, or they have a section, a very important section, that deals with global health. Population health is a little bit more complex because you know, it's demographers. It's a non-medical discipline on the whole. But even McGill has chosen to call its new school the School of Population and you know, global health. So I think the answer is that the schools that are not adapting to this new terminology are very rare, and like Johns Hopkins is really, I mean, a unique exception to this refusal to accept this new terminology. I think that certainly on the ground, I'm sure there's a difference between people who do public health in Hamilton and people who do public health, you know, in Botswana. Canadians who do public health in Botswana or South Africa, some of whom I know. I'm sure there's a real difference, but they work in the same schools of public health, and they cooperate with each other. They take votes on who to hire and things like that. So I think there is a merging together, a very real merging together of these areas. And you see it as well, even in some aspects of clinical medicine. I mean, who are the groups that are arguing for more emphasis being placed on mental health? It's largely psychiatrists. It's largely psychiatrists and psychologists who are emphasizing, who are looking at the global burden of disease and saying, hey, now we have proof that depression and anxiety are really serious problems in poor countries, and we should be spending more money doing it. So even with traditional clinical medicine, there's a closer, and many physicians that I know, I do an elective in the medical school. Okay, we do a course for fourth-year medical students, and part of that course is they get to choose from about 13 or 14 electives. I offer an elective on the history and sociology of global health. 20 medical students signed up for it. So many of them have already been, have worked in these developing countries, because they tell me they get such incredible experience that they couldn't possibly get anywhere else. And I have an older PhD student who's a very eminent cardiologist who has frequently spent 3 or 4 weeks in Africa or in Asia planting pacemakers, used pacemakers in people's bodies. So I think the world has become really a global village. It's not just a cliche. I think there really is a great deal of movement, and there's a great deal of overlap. And one of the things that makes the overlap possible is the vagueness of the idea of global health. I've come to the conclusion, after 40 years as a historian, that the things that really work are so amorphous that people with totally different interests and totally different perspectives can somehow find themselves in that kind of amorphous movement. And that's what creates successful social movements. Yes?
As an historian, it's quite extraordinary how much you do. Can you quickly synopsize what particular sources do you use? How do you deal with that problem?
Well, I can tell you that the problem of global health sources has more than once made me think that I have to abandon this project, because this movement, this social movement, this social enterprise produces so much written material that it's almost impossible to get on top of it. It's really, really hard. And then you add to that a lot of what's really important doesn't necessarily get into the articles. It's in archives. It's in archives. So I've been to the WHO archives, which unfortunately they are systematically destroying because they have no room. So they're literally, they're digitalizing a lot of it, and they're destroying other parts of it. But there are a whole bunch of other global health. Geneva is like a mecca for global health organizations. There are a number of other organizations that I need to go to take a look at their... I think the answer is that if I'm really going to be serious about this, I need to have a team. It needs more than one person, which is why for this SSHRC application, which is only about research, it's only about research policy. It's not even about actual research, it's research policy. I have 4 co-applicants for this, because I know it's way beyond anything that one person can handle. And I'm actively, trying to get more people involved in this because it's just so big. It's just so big. I long for the days when I went to the Bibliothèque Nationale and I would get a box, a filthy box, and I could get through with it if it was good material, in a couple of days. Now it really is overwhelming. I have no answer except you try to muddle through as best you can and try not to make too many mistakes. Yes.
I'm curious, from your perspective as a historian, how do you deal with the issue of emerging fields, historical ways of writing to how an area becomes like economics, quite good at writing.
So you're talking about disciplines, intellectual disciplines?
However you want. It's a very good historical writing about that. And does that inform your perspective here?
Okay, the question was, does the history and I guess the sociology of the emergence of disciplines inform, or fields, not just disciplines, but larger fields, inform what I'm doing? And the answer is very, very much so. The book that I wrote in 2006 was about the history of medical specialization and how medical specialties actually emerged. So I'm very conscious of how these things happen. But this one is a really tough one because you get the fact before you get the area of knowledge. People have been going to Africa and to parts of Asia since McGill has had groups there since the 1970s, I've also written a book on the history of universities, so I'm actually very interested in how it's becoming an academic discipline. But yes, there are no simple answers. One of the things that I mentioned is I think one of the secrets of successful social movements is being vague enough that a whole bunch of different groups that don't necessarily have the same interests find that it's useful for them to be part of a single social movement, moving and making certain kinds of demands for resources, doing certain kinds of activities, and publicizing what they do in a certain way.
So is it fair to say that your argument is that this is a social movement? Is that your argument?
Yes, I would say that that's a good way of putting it. It's actually several different social movements that are close enough together that people don't really distinguish them very much, but they're not quite the same thing.
But you don't see it as an issue of an evolution from the study of disease, because many of your examples really is global disease versus global health. So you don't see the dialogue as one that begins to inform the issue of global disease.
No.
Manifestations and blah, blah, blah.
No. I think global disease very much informs what is done, the actions. We're talking about specialists in specific diseases who are going to low-income countries and are doing the kinds of things that they're doing. The researchers are trying to find, in some cases, they're trying to find solutions to very difficult problems. In other cases, they are trying to find better or cheaper solutions to very imperfect solutions that already exist. But I think that there's a difference in. I don't want to become a sociological essentialist, but I think that there's a difference between how even groups do things and how institutions emerge, how social movements and institutions emerge. And obviously, it would be crazy to say that, disease and medicine has nothing to do with it. But one could imagine people doing what they've done for generations, what they did for generations. Groups of doctors and researchers going to spend a few years or a few months in Africa and doing what they can do. The fact that so much money is now being spent on this social movement suggests that you have to look, in addition to the technological and biological factors, you have to look at the social and factors that lie beyond it. I don't think the two, are contradictory. I mean, I think science and health are as social enterprises as any other enterprise, which just basically means that human beings in groups work on them and pursue them and function like social groups. I mean, we have a speaker coming from the Faculty of Management next week to our department who is looking at how robotic surgery is changing work patterns and social patterns on surgery wards. Because surgery is a social activity. It's technological, but it's also a social activity. People have to work together for it to function. Anybody who hasn't asked the first question? Okay.
I'm not sure if you mentioned this, but if you could just clarify, would you think that the next step of the evolution of global health would be to more turn into a social science which incorporates health science? Or do you think if it strictly speaks to health science in general, would that be...
Okay, well, let me tell you one of my dilemmas, okay? When people talk about research, which is supposedly what I'm trying to do research on, they mean two things. They mean more than two things. They mean, in some cases, very sophisticated biomedical, molecular research to deal with illnesses that are very difficult to control. They mean technologies that, if they can be put into effect cheaply, like good water, clean water, can improve health very dramatically. But one of the areas that is growing with incredible speed, and I'm very, very ambivalent about it because I actually find it very boring to read, is health systems research. Health systems research is really, really big. Okay? It's really big because since the 1970s, and this is one thing that the World Bank and the World Health Organization and Houghton Mahler and Ken Warren all agreed about, the only way you could actually improve health is if whatever resources were available were efficiently managed and distributed. So this is a huge, huge area, one in which the World Health Organization actually, I'm learning because I'm sort of gingerly putting my feet into it, is playing a major role. There are several different alliances of health systems research, and it's all about the various social, how the various social sciences and economics and organization theory, how you can use those to make health systems function more efficiently. So this is the next big thing, I think. This is the next big thing, and I have no doubt that it will become extremely important. It won't overtake the technology. Producing an AIDS vaccine is too sexy to ever be abandoned. Okay, it'll never be abandoned. But in addition to that, there's a lot of emphasis now on the kind of research that allows health systems to work better.
So I want to thank everybody for coming. We're at the end of our time. I want to ask you just to come and talk informally and please eat some cookies and drink coffee. And join me in thanking Dr. Weisz.